Welcome to our latest episode of the Lebanese Physicians Podcast. And today we'll be talking about eating disorders. And our guest today is Mrs. Carine El Khazen Hadati, who's a clinical lead for psychology services and director of the Eating and Weight Disorders program at the American Center for Psychiatry and Neurology in Dubai, the United Arab Emirates. And she is also a cognitive behavioral therapy trainer. And she has studied at USG in Lebanon and then at the Sorbonne in Paris and has lived in the UAE for the past 2 decades. Welcome, Dr. Welcome, Mrs. Carine El Khazen Hadati to the podcast.
You can call me Karine. Thank you,
Yeah, I
Dr.
know.
Diab, for inviting me. I'm very happy to be on this podcast and hope I can shed some light on this very important topic. So thank you for giving it its importance.
Yeah, I think it's an extremely important topic that encompasses, I think, a wide range of issues, right? From people with anorexia, bulimia to people with weight-related problems. So, can you tell us about your journey into the field of clinical psychology and what led you to specialize in eating and weight disorders?
So I studied in Paris, and the last year of my postgrad, so after the masters, you have to choose a specialty, and I chose eating disorders, and I learned actually very little, but I thought I learned a lot. So I arrived to the UAE to Dubai in 2004, and I started working in the polyclinic. So it was not a specialized mental health clinic like I do now. But please bear in mind that in 2004, mental health in the UAE was at its infancy. So we were a couple of psychologists in Dubai and even less in Abu Dhabi and the whole Emirates, actually. But when I started seeing this influx of families and patients that came to us very critically medically compromised, suffering from eating disorders and really reaching us towards the end of their journey. And I tried to do my best with my knowledge, what I studied. I was working with a family physician, which helped also. But soon I saw that I was unequipped to deal with them really the way they should have been dealt with. Whatever I studied was not enough. Of course, I used my common sense and whatever I had learned, and I think I did not do any harm. And I was able to help many, even at the time. However, I was very frustrated with really the very poor outcomes. So I knew something was missing, and I knew I had to go and research it and see what was out there, and what were the therapies specialized for eating disorders. And this is how I started my journey researching, and I discovered the CBT-E, which is cognitive behavioral therapy enhanced for the treatment of eating disorders. And I basically studied it, specialized in it, and then founded the Eating and Weight Disorders program at ACPN. So at the same time, I also worked with the Middle East Eating Disorders Association because I also felt that there was so much to be done in terms of raising awareness, educating parents, the level of stigma, the uneducation, even if I may say, of first line physicians like pediatricians or gynecologists. We had so much to do. And today I have left MIDA, but hopefully there's a new association in the making where we can continue our work.
Yeah, and that's me. That's sort of a coalition, right, of eating disorders specialists in the Middle East, in different countries in the Middle East.
Yes, and now it's inactive. But yes, initially we were a couple of eating disorders specialists, and we gathered to do this, to launch this NGO. And now doing the same with another association. Soon we'll be able to launch it. It's the Arab Eating Disorders Association. And now we are much more, we are already 80 specialized mental health professionals in the field of eating disorders. So from 4 to 5 to 80, for sure we have progressed, but there's a lot to do still.
Exactly, but that's a huge progression over time.
Yes.
which points to the fact that it's becoming like a more accepted fact and a more known fact that it needs to be treated. So my question for you as we discuss it is, how do you define eating disorders in a clinical context?
It's very difficult nowadays because disordered eating is so prevalent that it's very difficult to where to draw the line between disordered eating, which is maybe trendy, does not really have a high level of impairment on the person's life, and a full-blown eating disorder. For me, the key is the level of functional impairment. People who live with full-blown eating disorders cannot function. Really, it's very difficult. They might be able to function, but it takes a tremendous level of effort. So, all the areas of their lives are affected. These are people who can't socialize really, who become isolated, who can't function at work or really at school. They're really struggling. They have health problems. If not physical health, which most of them do, it's at least mental health problems. Disordered eating, though it's, I believe it warrants to be treated also, is not as impairing on daily basis.
Yeah, so basically what you're saying is it's a disorder of eating, like a severe disorder of eating that also affects the mental health of the individual. Is that,
Yes,
am I
and there's
correct?
this underlying, we call it the over-evaluation of body weight and shape, which means the whole self-esteem of the person is solely based on controlling their body weight and shape. It's different from body dissatisfaction that is widely prevalent in our culture, society, in the world today. Every person you meet, if you ask them, would you like to lose 2 kilos, they would say yes. But thankfully, not everyone will go to these extraordinary lengths, such as starving, purging, taking unwarranted weight loss medication to achieve this target. So, really, the sense of self is based on controlling body weight and shape. And this is the underlying psychopathology of eating disorders, which is not shared with people who have disordered eating.
Right, right. And what is the mission and approach of the Weight and Eating Disorders program at the American Center, as we discuss further?
So going back to 2004, I reached Dubai and there's nothing. As I said, mental health is at its infancy. And if you look at the region and even Lebanon, which I believe always had excellent and pioneering mental health services, also there was nothing. So no residential treatment facilities, so no rehabs, no specialized inpatient. So really, there was really nothing. So so we had to do something with what we had. And in the UAE, it's very difficult to set up. I mean, all hospitals and entities have to be governmental. Now, this year, it's starting to change, but we could not set up any rehab or anything of the sort. And anyway, the preliminary data showed that it's always to treat eating disorders as an outpatient when possible, because especially for teenagers, they stay within their families and they can go to school and they're not completely cut off of their friends group, etc. But with basically nothing and this influx of patients, as I said, I started to research and found CBT-E, which I decided to use because it's trans diagnostic, so it can be used with all the diagnoses because it targets this underlying core psychopathology, which is the same. And no matter what the diagnosis is, all patients with eating disorders share this underlying over evaluation of body weight and shape. So this is what it targets. So it's flexible with modules that you can adapt depending on, of course, the diagnosis that you're treating. It's a therapy that you can use across all age groups. So it was initially designed for adults, and now it's been adapted, I think, 10 years ago for adolescents. And it's also being able to be, you can use it for older adults as well. This is also, we see, older adults suffering from eating disorders. It is the gold standard. It is an evidence-based therapy. It has been, researched. There are multiple studies, real-world studies, that show its efficacy. Recovery rates are between 50% to 70%, bearing in mind that before we had evidence-based therapies, the recovery rates were around 15%. So it's a huge difference. So we decided to set up this eating and weight disorders program for the region, because again, there was nothing. And the fact that we had a multidisciplinary team, especially a family physician specialized in eating disorders, allowed us to cater to extremely low BMIs and very medically compromised patients, because we did not have another option. There is no inpatient, no residential treatment facilities, so we had to do what we could basically in our center, in our outpatient center. So the mission, in short, is to offer the best evidence-based treatment to the majority of eating disorder sufferers.
And can you describe to us a bit the treatment of, because a lot of people probably don't know what cognitive behavioral therapy is. So how does it work, and how do you do it?
So it's different from your traditional CBT, which I guess everyone knows. This is a specific type of CBT that has been designed by Christopher Fairburn in Oxford. So in the 2000s, I think the first studies came out. So it was still, it's not that long ago, if you think about it. And this is someone a psychiatrist who treating patients in Oxford, realized that there was a common theme for all patients who suffered from eating disorders. And basically this theme is this body image, this over-evaluation. So he created a protocol. It's very structured. You have stages. It's extremely engaging. So the first stage is, we call it starting well. So really you do lots of psychoeducation. You make your patient an expert into his eating disorder, and you show him how he is caught up in vicious cycle, self-perpetuating cycles, so that he makes the informed choice to break free from it, so that he understands every procedure that is going to be implemented. And when he agrees for that, then you move to the stage 3, which is basically working on the underlying core psychopathology, which is the body image, which is the dietary module, so the restriction, which is emotional regulation. And then there's a big part on relapse prevention, because as you know, these disorders are, at very high risk of relapse. So it is time limited. For underweight patients, it will be a 40-session treatment. For non-underweight, it will be a 20-session treatment. The reality is that it's a bit more than that. But let's say this is the protocol. It's a doing therapy. It's not a talking therapy. Patients are expected to work on their eating problem. There's a lot of in-between sessions assignments. So they are actively working on breaking free from these self-perpetuating cycles. There is big behavioral aspect and a big cognitive aspect. So for example, when we start the treatment, no matter what the diagnosis is, we establish something called regular eating. Regular eating is having 3 meals and 2 snacks and nothing in between. So it is very active, it's very on the ground, it's very pragmatic, if you want. So we give them clear, it's not instructions, because we do not do anything the patient does not agree on. It is a highly collaborative therapy. Even with teenagers, it is really not family therapy. It is an individual therapy with the teen, where we engage him, we educate him, and then he makes the decision to make the changes. And the parents support only if the teen is in agreement. So it gives him a sense of control, and it works beautifully.
Yeah, and basically, and here we're talking about targeting mostly the underweight or the anorexia and bulimia patients with body image problems. Do you also deal with like overweight or obese teenagers, let's say, or adults?
Yes, yes, yes. Now, no, the CBT is not only for underweight. You have two protocols. Actually, the first protocol was for non-underweight. Chris Fairbairn worked on bulimia nervosa initially. It has been adapted for underweight. But the idea is that you are right. There is a subgroup of patients who are in larger bodies, okay, and who do not have a binge eating disorder, or who could have a binge eating disorder. However, the body image is much less present than someone with anorexia or bulimia. But we still touch upon it though. So I don't know if your next question is, do we work on weight loss? Is this the question?
Yes.
Yes, it's a big question. So I'm going to say yes and no, I guess. First of all, let's say we have a case of a patient in a larger body who presents with a binge eating disorder. The first mechanism of binge eating is dietary restriction. So it is impossible and the patient is usually binging because they are attempting unsuccessfully to restrict their eating. Physiological deprivation, being in a state of starvation, which is basically having a calorie deficit and being deprived from food groups, is the first reason for binge eating. It is not emotional. Emotional comes after. It becomes emotional. But there are strong physiological and cognitive urges to eat when you are underweight or you are under eating, because your body is primitive and is going to push you to find food whenever you're deprived from it. It doesn't know you're on a diet. It thinks you're starved. Our bodies did not evolve that much. So we cannot put a patient even on a very flexible and a non-restrictive weight loss diet when they are binging. It's impossible, because they are going to be binging more and more and more and more and gaining more and more and more weight. So the first step is always to treat the eating disorder. And when you're treating the eating disorder, what is happening is that you're also working on the body image, correct? Now, a lot of patients, and you would be surprised, after we finish the protocol, do not wish to lose weight anymore. Some of them do. Some of them do, and they do because they have health reasons, or they are they have an important psychosocial impairment. These are people in obese or morbidly obese who cannot travel, who cannot have sexual relationship, who cannot really move freely. So even if you have solved the relationship with food, and if they have reconciled with their bodies, they still will benefit from losing a bit of weight. Now, our approach is non-judgmental, and we understand that it is very difficult to live in a larger bodies in our time and age. We live in a terrible fat-phobic society where weight stigma is horrible and does more harm actually than the actual excess weight that some patients might have. So we hear their concerns, and you know, we take them where they want to go. But of course, if it's not recommended, then we are going to say that it's not recommended. So, for example, if you have a patient who's not below their genetic set weight, they are, who's not above their genetic set weight, who have successfully cured their relationship or improved their relationship with food and have a better body image, do they need to lose weight? A lot of them have great, blood tests and don't have medical complication. It's also another misconception that we have. So that we do also a lot of education on the concept of genetic set weight. We inherit, a body type and a body weight, more or less. It's very difficult to change it. If you want to go below it, you might binge eat or develop some, complications. You have lifestyle expectations. Is your weight expectation in line with your lifestyle expectation? Don't forget also food plays a big role in this population. There's a lot of dopamine that they're used to receiving, so not eating that much might, cause depression or low mood. So they are educated at the end. If they still want to lose weight, then we help them. We use very flexible, non-restrictive approaches. We educate that 5% of body weight loss is enough to reverse most metabolic conditions, or at least improve them, and will improve quality of life tremendously, especially if we pair it, which we should, with some physical movement. Doesn't have to be exercise. We know that today physical movement is the most important predictor of health and longevity, and trumps by far BMI, which doesn't mean much really. So we do that, but of course there is a subcategory of patients with whom we cannot do that. So for example, patients who have recovered from restrictive eating disorders and maybe now are at a, for them, higher body weight, but it is their genetic set weight, and going below that means they have to live with an eating disorder. So there are some exclusions for sure, but I promise you, a lot of them don't wish to lose weight at the end of the treatment.
But that's also an interesting concept, actually. I didn't know about a genetic set weight.
Oh, yes.
And that's why I think you always question, like there's people who say, oh, you know what, I don't eat as much as this person, but this person's always thinner than me or something like that. And it may be part of the genetic set weight that happens
This
with
is
that.
this whole myth of I have a fast metabolism or I have a low metabolism is actually just your genetic set weight. When you have a thin genetic set weight, definitely you can eat more and maintain this thin weight. And when you have a higher genetic set weight, whatever you're going to eat is going to go towards pushing you towards your genetic set weight, which is heavier maybe than someone else. So this is absolutely true.
I learned a lot from you now because I used to think this is hearsay, and now like it's like, okay, this is
No,
it.
no, no. There is, we inherit a number of fat cells and a disposition of fat cells. And we can, and it's, you have 15% margin around that. It's not a point. We'll say it's a defended weight range. And if you go below this, your body is struggling. Your body is not happy. And this is why you see a lot of patients in larger bodies who suffer from what we call atypical anorexia nervosa. A big misconception is that you have to be thin and emaciated to be diagnosed with anorexia nervosa. The reality is that up to 50% of patients with anorexia nervosa are in higher body weights or normal body weight, quote unquote, but they are starving to maintain this high body weight because they should be even higher. And they have exactly the same symptoms as someone who is underweight. The only difference is that they don't have bone issues. They don't have osteoporosis because they carry more fat, which protects the bones and the hormones. But other than that, they have exactly the same symptoms.
That is a very interesting concept too, because everybody thinks that anorexia means somebody's very thin or malnourished, and that's not the case a lot
I
of the
mean, they are
times.
malnourished, these
Yes.
patients, but they are in a normal or higher body weight. And when they are losing weight, this is also the effect of weight stigma in our society. Healthcare providers recommend weight loss. I mean, they are well intentioned, and that's what they know, right? That you have to lose weight in order to be healthier. And or if the patient has lost a lot of weight, we don't know. They don't take a history. They are not asking how did this patient lose weight. Are they purging? Are they taking substances that they shouldn't be taking? Are they starving to lose weight? They don't. So they praise it and the patient perpetuates. And these are the hardest patients because they come to us very late in treatment, and prognosis is very much linked to early intervention. And also, it's very difficult for them to accept being in a higher body weight because they suffered so much from fat phobia and weight stigma. So it's a very difficult work. Sorry.
And this is a good segue actually into how are patients, how do they come to you? How are they referred to you? Are they self-referred? Are they referred by their primary care physicians or providers? And then uh, bridging into that, as you said, like early treatment. So what is the efficacy of therapies or cognitive behavioral therapy enhanced in treating these weight disorders?
So as I said, the latest numbers range between 50% to 75% of recovery. For anorexia, it's lower, and for bulimia or binge eating, the rates are higher. Patients now, I've been doing this for 2 decades in the UAE, and and there we are not that many doing that. So clearly, I'm the eating disorder person, and we have the only really MDT evidence-based eating and weight disorders program. So we have a lot of referrals because we are basically known in the community. But are we getting as much as we should? Not that we want to work more because we're overloaded, but for sure there is a lot of underreported and misdiagnosis. One of the reasons is the whole weight stigma, where patients in larger bodies are not diagnosed. The second is men. There's a huge also misconception that men don't suffer from eating disorders, which is very, very wrong. So, and men in our culture are even more sensitive to issues of mental health, and even more issues that have to do with food issues, right? So also men don't get to us early in treatment enough. And basically, you have to think if you can intervene within the first 2 years of the development of the disorder, your prognosis is significantly better. The longer, really early intervention is key. The longer the disorder, the more ingrained it is, the more it becomes your identity, the more you have lost other areas in your life that could compensate for, being obsessed with your body weight and shape. And the more you are going to, because there is nothing else anymore, it's a vicious cycle. The only thing that matters is this body image, etc. And we do have a category of patients who we call severe and enduring anorexia nervosa. So these are patients who have lived with the disorder for more than 10 to 15 years. They don't come often to treatment. When they come, it's because medically they are starting to really struggle. Though you would be amazed how the body adapts. Really, this tells you how our bodies are wonderful, because your body does adapt to starvation after a while, and sometimes the medical, the complications are not as bad as what you would expect to see. There is no evidence-based treatment for this category of patients. So there is CBT-E has been, and the rest have been more tested in adolescents and adults, and people who have had the disorder for between, let's say, 0 to 5 years. But more than that, we don't really have a treatment for them. However, we use CBT, and sometimes we do very well. So they are treatable, and eating disorders, you can recover from an eating disorder at any point, but it's easier if the intervention is early in the onset of the disorder.
Yes, what you're saying is diagnose early, be at the lookout, and refer early, because that's going to lead to better outcomes for these patients. Which brings me to the societal norms, because we talked about like men in the Arab world and stuff like that. They don't want to be referred, or they probably don't want to say that they have any problems. So do you still deal with a lot of societal norms at this point, or barriers for patients to be referred to you?
Yes, definitely. I mean, if you think that 1/10 sufferers in the world will be referred to a treatment, so 1/10 patients gets to treatment, let's say. This is in the West. For us, I would say even less than that. I would say 1/20. So I think, again, I go back to weight stigma. A pediatrician, tell mothers to put their kids on diets. The kid starts a diet. Maybe he is developing an eating disorder, but he's praised. So this is misdiagnosed. Men, in our culture, it's very common for men to go in the morning, not eat, go to their day, to their work life, come back, and then have the main meal in the afternoon. And these are usually actually binges. And this is normalized also. So on top of the normalization of certain eating habits, you have the whole stigma around men and mental health, which is extremely prevalent in our region, especially in the GCC, more so than in Lebanon, because Lebanon has a long history of, mental health treatment and care, etc. And then we have Islam and Ramadan. Fasting during Ramadan is unfortunately a big trigger of eating disorders as well, because it's the perfect opportunity to starve while being praised and while doing it without anyone looking at you or commenting on what you're doing. The other one is the veil in veiled women, because you can be losing lots of weight and dissimulating it perfectly. So there's a lot of cultural aspects that come from our region and that needs adaptation.
Yes. So my thing with you is, as we go through, is what is the influence of social media and influencers, I guess, on weight perception, and are they perpetuating eating disorders when that happens, and mental health issues?
Yes, definitely, definitely. I mean, social media is a whole topic on itself, which I think warrants another podcast. But just briefly, I think the detrimental effect on social media on mental health, especially of teens, is very well documented. If you go back to eating disorders, you need to know that this over-evaluation of body weight and shape thrives on comparison and comparing oneself. What does it mean? It means that someone with an eating disorder is constantly comparing to people around him, okay? And the way they compare is a biased way. They will always find a person thinner than them or more beautiful than them, etc. So before who did we compare to? Our classmate, maybe a celebrity on a magazine, your neighbor. Today, they are bombarded because of the algorithm with one type of images all the time, which are these, perfect figures, thin, skinny, completely unrealistic looking girls and boys, which are basically fake because they are the result of Photoshop and filters, etc. So basically, the young sufferer is bombarded with these images all the time, and for him, what is the the reality is that everyone looks perfect, and he's the only one who doesn't look like that. So I need to go diet and restrict to achieve this. It's unfair. I should be looking like all of them. But these images are fake. They don't exist. This is one. And if they do exist, they are a very small minority of the population. Most people are in again, I don't believe, not myself, but even the scientific community doesn't use the BMI anymore. But if we were to use the BMI, the majority of the population is a BMI between 25 to 35, which is considered, if anything, overweight. But when you're on social media, you don't see these people. You only see those constant images that are perfect. And influencers, they are being paid, they are sponsored to pay weight loss diets, they are being paid to promote weight loss diets, to promote means to achieve their own supposedly figures, etc., etc. It's also the trend of healthy eating, clean eating, etc. So they are, promoting certain types of food, etc. So it is disastrous, the effect it's having. Anyway, the data are stark. If you look at all the data, a body image 2021 meta-analysis found that social media use is strongly associated with body dissatisfaction. Up to 71% of adolescent girls and 53% of boys reported that it made them feel worse about their bodies. And.
Yeah, because basically you're selecting for a certain population of people on social media. You're
Algorithm,
not
yes,
seeing the real world.
exactly, absolutely.
And as we look, I think ahead, and as we look at also regional challenges, so basically, when you look ahead, do you feel that the future is bright for the treatment of eating disorders and potentially the prevention of these disorders? And I guess this all depends on in the region too. Like, are people aware of those disorders? Is it becoming more of a less of a taboo, I guess, to get them treated?
Yes, we are in a better place, but we are far from where we should be. Bear in mind the situation of eating disorders in the world is not great. So, your mainstream treatment is still obsolete. Even in the US, we call those centers the revolving doors. The kids come in, they get fed, and then they come out, and then they relapse and they come back in. So very few centers in the world really have adapted to evidence-based treatment. Some have, but we need more even in the world. So actually in the Middle East, we're not that bad. I think, there is a lot to be done. But as I told you, so when I started, I was the only one working with eating disorders. Now in the region, we have 80. A big mission of mine is training professionals in being able to deliver evidence-based care. The majority of the population thinks that if you have an eating disorder, okay, if you are, educated enough to notice it, or if you go to a good doctor who is going to diagnose it, you think that if you go to any mainstream psychologist, it's enough. It's not. These disorders require specialized treatments, and the difference in terms of recovery is huge. So we need more people in the region being trained to be able to cater to a majority of sufferers. We also need more prevention. This thing about this war on obesity in schools, especially in the GCC, it's actually creating more obesity, and it is actually fueling eating disorders. You go and you tell kids to diet and to cut this and to cut this off, and if you don't lose weight, you're going to have diabetes and I don't know what, and people go on diet, which, diets fail. 95% of all dieters regain all the weight lost and more between 1 to 5 years after the last diet. And 35% of these develop at least some kind of disordered eating, and 25% of those 35 develop full-blown eating disorders. So the public health policies have to change also. The speech in school, educators, parents, there should be a shift. We have to fight weight stigma, because weight stigma fuels the dieting industry and all these big, wars on obesity and all these big initiatives. So it's great to have more people trained to deliver the best treatment, but it would be even better if we didn't have to, and if we didn't have these sufferers to treat. And this would go through prevention, this would go through stopping some initiatives, this would go through having some clear and enforceable policies when it comes to social media. We need disclaimers on altered or filtered images. We need bans on weight loss products, advertising. We need to restrict influencers. We need national media literacy campaigns. We need a lot. So treatment is great, and I'm very happy to be at the forefront of this mission of training more and more professional. Now we have an upcoming CBT-E training with Oxford, with the University of Oxford, that has been culturally adapted for our population, because we believe that we need to have culturally sensitive treatments too. These are Western treatments, but we need to be able to use them. So we've adapted a section on Ramadan, fasting, and body image adapted to veiled women, etc. So that's great to treat, and it's great to have evidence-based treatment, and it's great to tailor them to be culturally sensitive, but we need also to work on prevention. We need to raise awareness. We need to be able to get the sufferers earlier in treatment. We need people in larger bodies to not be dismissed and to be, fairly diagnosed. We need also men to step out of their comfort zone and feel comfortable enough to consult for such issues.
Yeah, and this could be, I guess, and you are working on some of this, I think, with the new association that you're developing, right?
Absolutely. Absolutely. This is really our aim. So really raise, first we need also to have better research. in our part of, we are really missing those, nationwide big cohort studies on eating
Yeah,
disorders.
because you need the data, right? You need the baseline
We need the
data to
data,
work on.
absolutely. We need the data. We think that, I mean, we have preliminary studies that have been conducted here and there, but we don't have anything big. What we have from what we know is that the rates of our eating disorders sufferers is at least equal of those of the West. However, we think that they are superior because don't forget, we are a region that is, I mean, we are struggling with trauma, PTSD, food insecurity, and all of these are highly correlated with the rise of eating disorders. So some studies, for example, in Al Ain University found that the prevalence of anorexia nervosa in the female population was 1.9%, where it's a 1%, for example, in England. So there's another study in Lebanon done on disordered eating, and students also found that 75% of the girls were struggling with eating disorders, 50% of boys. But we really need data, as you say. We need data because this data is going to hopefully help us work on policies
Right.
and change and help with prevention. So we need data, we need to raise awareness, not only parents and educators, but medical doctors. Medical doctors are at the really the forefront. They are the first line. They see the patients first. They don't, I mean, the patient doesn't come to the psychologist directly for an eating disorder. Most of the time they are referred hopefully by either the school counselor or a doctor who knows enough to be able to detect an eating disorder. We need to also bring the region together. So we need to have hopefully a residential treatment center because yes, we prefer to treat our patients as an outpatient. It's better, but sometimes we can't. We need the center, we need the inpatient, but we need it to be specialized because otherwise, if you put an eating disorder patient in a general psychiatric ward, they are unlikely to get better. A lot of them get traumatized from that stay, and they come out of it even worse than what they were. We need, as I said, to educate parents. There's a lot to be done, but hopefully we are more now, and hopefully we'll be able to change the face of eating disorders in the region.
Yeah, Karine, thank you so much for being on this podcast. And I think just to summarize to the listeners, I think the key is prevention, awareness are the most important things because once the eating disorder sets in, it gets slightly harder to treat, right, with the relapses and stuff. And then early, if it happens, early diagnosis, early treatment are what was the most important at that point.
Yes, but for sure, eating disorders are, disorders that respond very well to treatment if it's the right treatment. So of course, early intervention is key, but it doesn't mean that if someone has been living with an eating disorder for some years, it's not a death or a life sentence. So I encourage everyone to seek help because recovery is possible at any age and at any stage. However, when possible, early is of course better, linked to a better prognosis.
Thank you, Karine. I think I learned a lot on this podcast.
Thank you very much for inviting me. It was a privilege. Thank you. I enjoyed the conversation.